The first speaker, this is a US-UK session. Our first speaker is one of the grand dams of North American PAG. She is the editor of the premier journal for pediatric adolescent gynecology. Needs little introduction. Honorary Fellow of FIGIG, Paula Hillout. Thank you.
Thank you so much. So thanks to the organizing committee, in particular Dr. Zoran Stankovic, who invited me to come to this lovely city and this to be able to meet all of you and many of you and to talk about a topic that is broad enough that I can take it in the direction that I'd like to take it. So I was given the challenge of talking about challenges to the sexual and reproductive health of young people. And so I'm going to give us a bit of a look backwards and a look forward as well. I have the following disclosures. And I'm going to take us with a time machine looking backwards and then forwards. So I want us to look backwards because I think we need to look at some of the things that are better now than the time when I was born. I was born in 1952. I'll spare you the math. I'm 71 years old. And in my lifetime, I have seen a number of positive changes. In 1960, the U.S. Federal Food and Drug Administration approved birth control pills. Now, that was in enough time for my adolescence, but at the age of 18, it was still difficult for a single young woman to access birth control pills. But now that is not so much a challenge around the world. The 1960s and 1970s were a time when we started to think and talk about the environment. I remember the first Earth Day in 1970 when I was 18. Feminism was something that we assumed. I don't think we can yet assume it, but we also talked about zero population growth, which is not something we talk about so much now, but we are aware of the effect of population on the environment. In 1972, in the United States, Title IX legislation was passed. Now, Title IX is legislation that prohibited sex discrimination, and it's widely interpreted as referring to sports. It does refer to sports and sports teams. I have to say that when I was in high school, there were no school-sponsored girls' sports teams. They just didn't exist. I think that's news to many of you all, because now girls' sports are very important for girls all around the world. Title IX did that. Title IX also has been interpreted in the United States as prohibiting sexual assault and sexual harassment. So more broadly, interpretation of Title IX, and that's progressive. In 1973, the Supreme Court ruled in the decision on Roe v. Wade that abortion would be legal in all of the states of the United States. And that was huge progress. If one looks at a map of access to abortion prior to Roe v. Wade, you see the vast part of the United States, the vast middle of the United States, abortion was illegal. But now, up until very recently, up until this year, it was true that across all states in the United States, adolescents and others could access abortion. In 1973, the book Our Bodies, Ourselves was published. It was mind-blowing to me. It empowered young women to understand their bodies, to understand our physiology, to understand the power that we had together. And that really helped to shape who I am and what I have done. So the combination of the Supreme Court decision of Roe v. Wade and the feminism movement and empowerment of women led me toward a career in medicine and toward a career in gynecology and toward a career in pediatric and adolescent gynecology. In 1981, I was the first female faculty member in the OBGYN department at the University of Virginia. And as such, my colleagues in pediatrics kind of latched onto me and really made me aware in a way that I had not previously been aware that girls and adolescents had gynecologic problems. They had really been ignored prior to that time. And so taking up that mantle and beginning to talk about pediatric and adolescent gynecology, I found colleagues all across the US with the beginnings of the organization that is the North American Society for Pediatric and Adolescent Gynecology. So that organization, and internationally, nationally now, we have Fiji's and we are working together. So all of these are steps forward. Not everything has been a step forward. There have been some steps that haven't gone forward in ways that we had hoped that they would. In the 1970s, there was a move in the United States to pass an amendment to the US Constitution that was the Equal Rights Amendment. It didn't pass. And in fact, just in the last month, the US Senate took up the issue and decided not to go any further with it, even yet and still. So we have a ways to go before an amendment to the US Constitution guarantees equal rights for women. And then earlier this year, the decision of Dobbs from our US Supreme Court overturned Roe v. Wade. And one can look at a map now, it's available on the guttmacher.org website, that tells us month by month states that are adding restrictions for abortion. And the map of today looks almost like the map did prior to Roe v. Wade, and that is of huge concern. So we have made some progress, very definitely, but we've also taken some steps backwards. And on some days, I feel we've taken 2 steps forward and 1 back. And on other days, I feel we've taken only 1 step forward and 2 back. But together, I think we have work to do and we can move forward. I want to raise up a concept of reproductive justice that was first raised by a group called Sister Song. It's a group of African American women, women of color, reproductive justice collective. And so they started talking about reproductive justice in a way that was, I have to confess, new to me. But I love the concept, and I think it should be our framework moving forward. Sister Song declared in 1994 the human right to own our bodies and control our future, the human right to have children, the human right to not have children, and the human right to parent the children we have in safe and sustainable communities. We don't talk so much about reproductive justice yet, but perhaps with your help and the help of others, we will start talking about it more. We do talk about economic justice, we talk about racial justice, we talk about environmental justice, we talk about social justice, we talk about reform of the criminal justice system, and I have to say the so-called justice system in the United States. But only recently are we starting to talk about reproductive justice, and I would encourage us to talk more. My framework growing up was reproductive rights, and in particular, abortion rights. But the concept of reproductive justice raised by Sister Song was amplified. Hillary Clinton made the statement, human rights are women's rights, and women's rights are human rights. We need to expand the rhetoric beyond choice and acknowledge the context in which many women do not feel that they have a choice. So the concept of choice wasn't real to many women. The UN has given us some framework. It is my challenge to follow Dr. Chandra Moonley and his wonderful talk and how inspiring he was to us. But we need to look to the UN, and we look at the UN Sustainable Development Goals. And of those 17 goals, there are 3 that particularly focus on sexual and reproductive health. The goal to ensure healthy lives and promote well-being for all at all ages. The goal to ensure inclusive and equitable quality education and promote lifelong learning opportunities for all. And the goal to achieve gender equality and empower all women and girls. More specifically, this publication from UNICEF, the Global Strategy for Women, children, and adolescents' health. Now that seems intuitive to us that adolescents would be included, but it was only in 2015, prior to the publication of these goals, that adolescents were added to women and children's goals. We all know that there are unique challenges facing young people. Those are the challenges we deal with on a daily basis. The other thing this publication did, and the recognition adding adolescents to the strategy, is acknowledging their pivotal role as key drivers of change. We know it is their future, but all you have to do is Google young women who are changing the world, and we'll see the faces of women that we all recognize: Greta Thunberg, Malala Yousafzai. These are young women, but there are many, many more young people, and young women especially, who are looking to change the world and who are speaking to the world about what we need for the future. Included in the global strategy are the goals to ensure universal access to sexual and reproductive health care services and rights, including family planning, and to eliminate all harmful practices and all discrimination and violence against women and girls. These are important goals and strategies. There's a little more elaboration on these sexual and reproductive health goals and strategies within the UN context and global goals, sustainable development goals from the Guttmacher Institute. And I don't want you to look at the details, but they're looking at what is measurable. How are we going to measure that we have made progress in these areas? So making these goals actionable. I'm going to switch gears just a bit, and I'm going to channel Professor Minerva McGonagall from Hogwarts. And I'm going to look as if I had a crystal ball. I would love one. I tell my patients that this is what I need to be able to tell them whether they'll have side effects to a particular medication, what will happen for them in the future. But I'm going to try to take a look at the future, and I'm going to ask you all to dream a bit with me, and to dream not small about the individual goals. On a daily basis, we take care of individual patients. We focus on our individual passions, contraception, sexuality education, whatever it is that we've heard about in this conference. Every single talk, every single speaker has been passionate about a particular focus and area of pediatric and adolescent gynecology. But we are so much in the now that we're not thinking about the next. And I am included in that. When I was given this topic, I started to think about what I could talk about. And there are lots of things that I could have chosen. But I chose to dream, and to dream big, to dream about what this world would be like if every single one of our goals were actualized, if we really met all of those things for the future. So I'm going to ask you to imagine a world. Now, I did have a clip from John Lennon's Imagine here, but I was told I cannot play audio clips, so you cannot hear it. But hear it in your mind, how we can imagine a better future. Again, the goals from the UN and thinking globally. All schools would provide age-appropriate, comprehensive sexuality education. You've just heard a wonderful talk about this. We can all work toward this. There would be universal access to reproductive health and reproductive rights. There would be respect for women's sexual autonomy. It would be assumed that women's sexual autonomy would be respected. Sexual harassment and assault would be eliminated. All individuals would have a basic knowledge about sexual and reproductive health and rights. Sexual and reproductive health care services are universally available for all and included in all national policies. So these are the global goals. But I also wanted to think about what it would be like for me as a pediatric and adolescent gynecologist in my day-to-day practice to have all of these things actualized. So I'm going to list some things that for me would be different, and these are my goals, some of them very big, some of them corresponding to the UN goals overall, but some very big goals and some very little ones. So in my future of my dreams, every child would be a wanted and planned child. Prenatal and postpartum care would be universally available. Female genital mutilation and cutting would be eliminated. The UN estimates that 1 million women a year are at risk for female genital mutilation. We've heard about adolescent births. We saw the slide that shows that we're doing a better job. The US is doing a little bit better, but we're still at the bottom of developed countries in that respect, but making progress. So adolescent births would be infrequent, and those pregnancies would be planned. And then some more specific goals. From birth, if there were a question of differences of sex development, a multidisciplinary team would be available to evaluate the infant, to work with the family, and to work with that child over the course of their life. Mullerian anomalies would be recognized early and appropriately managed, not the botched surgeries, the wrong surgeries of the patients that come to me after they've had the wrong procedure done. Growing up, kids would learn anatomically correct terms. What a concept to not talk about the vajayjay or other euphemisms because people can't say the word vagina. And dream a little bigger. What if people knew the difference between vagina and vulva? Wouldn't that be interesting, okay? So things could be different in the future. Again, universal age-appropriate sexuality education for all. Again, we've been challenged to work on this one. HPV vaccines would be universally available. Everyone is vaccinated. There would be vaccines against infectious diseases, including HIV. STIs, including HIV, would have been eliminated. What a future. But I'm not done. All primary care clinicians would be well trained about what is within the wide range of normal and what is not with regard to menstruation, puberty, growth, and development, including labial anatomy. Adolescent-friendly care would be the norm, with a focus on confidentiality when necessary and working with families toward family-centered care, but with that adolescent-centered and confidentiality if needed. Care would be easily accessible, hopefully maybe in schools. That would work for many kids. Some kids aren't in school, so adolescent-friendly care would be more widely available. Menstruation is handled with dignity. Period poverty is eliminated. Everyone is tracking their menses and aware of the relationship of menstrual cycles to health and disease. Everyone is aware that nonsteroidal anti-inflammatory drugs help dysmenorrhea. Dysmenorrhea is so often minimized. It's told that it's just what women have to bear. It's part of the curse of being female. It is not. We can help. We can help. And so many individuals, so many adolescents do not know that. Primary care physicians would manage or refer dysmenorrhea that was not relieved by NSAIDs. The possibility of endometriosis for those adolescents would be considered early, and hopefully we'll have new methods of diagnosis and be able to manage endometriosis appropriately. All clinicians would be well trained to screen and refer adolescents and young adults for mental health issues. But that screening isn't enough. In the future, if we are dreaming bigger, mental health services would be easily available for adolescents and young adults. Sexuality would be recognized and normalized as a part of being human. And to that end, I show you the genderbread person that I hope you are familiar with, and if not, here it is. Highlighting the similarities and differences and overlaps related to biological sex, gender identity, gender expression, sexual and romantic attraction. Related, but not the same thing, and often so confused. There would be a focus on consensual and safe sexual activities, protected with condoms, although if we've eliminated STIs, condoms might not be quite so important in some relationships. There would be effective contraception, perfect contraception that didn't fail, contraception methods that did not have significant side effects, modern contraception. If one looks at data from the UN about access to modern contraception, which includes everything from condoms up through long-acting reversible contraceptives, we see that there are significant portions of the globe where only a small portion, less than half, of adolescents have access, of women have access to modern birth control. So in my future, perfect birth control would be universally available. Child marriage will have been eliminated. Abortion is rare because we have perfect birth control, but would be recognized as integral to health care. Unsafe abortions will have been eliminated. The UN estimates that between the years of 2010 and 2014, 25 million women had unsafe abortions. And going on, the pathophysiology of gynecologic conditions, including heavy menstrual bleeding and polycystic ovary syndrome, would be well understood with early diagnosis and management, preventing anemia and preserving fertility. There would be societal messages, including body positivity for all shapes and sizes. Both obesity and eating disorders are understood, screened for, and managed in a holistic and multidisciplinary manner. Social media platforms contain safeguards for young adolescent users, as well as accurate public health messages, while eliminating fake news. And finally, as we've just heard about this morning, surgeons are all dedicated to saving ovaries, including those that are torsed. So thank you for coming along with me on my journey of the future. Take a look at the advocacy statements from both NASPAG and from Fiji's. We have work to do, but advocacy is a major part of what we have to do. We have to all speak up. We have to all work on our individual areas, but together we can make a future that is closer to what we want. Keep in mind that reproductive justice framework. It's important. And finally, I'm going to share with you some words, again, from Sister Song. And I'm going to ask you, perhaps, to close your eyes, because I'm going to give us the words from Sister Song, which I think are quite beautiful words. Our vision and what we are fighting for. We are dreaming ourselves into the future, fighting like revolutionaries. Our vision is a future rooted in human dignity and worth, bodily autonomy, joy, love, and rest. Reproductive justice is our framework. Intersectionality is our lens, and liberation is the goal. Reproductive justice leads to futures we do not yet know, but dare to imagine. Liberation is giving the land back to indigenous people who stewarded it and protected it for generations before colonization, and who live on it today. Liberation is having what you need to keep your kids, care for your kids, and keep your family safe and together. Liberation is choosing your family and being able to care for yourself and your community. Liberation is an end to police, prisons, family surveillance, and detention centers which are designed to harm Black and brown bodies and break up our families. Liberation is building communities where we all feel safe, able to experience joy, and live together with our loved ones. Liberation is ending the war on drugs and providing physical and mental health care, help, and support for everyone who needs it. Liberation is reparations. Liberation is abortion care for any person who needs it. Liberation is sexual consent, pleasure, and joy. We will not be silenced. We will take up all the space we need. We will lead with love. We will reclaim our power for ourselves, our beautiful families, our children, and the generations to come. So may it be so. So short of having a magic wand, and I borrowed this one from my granddaughter, I wish it worked, but we all need more than magic wands. We do face lots of challenges. In the United States, we face laws today that are really harming women, adolescents, and children. The reversal of Roe v. Wade, the laws in some states that are anti-LGBTQ, the threats to accessing reproductive health care, the threats in particular to abortion care and care for trans individuals. If I had my sound effects, I would have a clap of thunder right now. But how do we have hope? How do we avoid despair? And I would say that the way that I do it is by looking to you, to look to my children, to look to my granddaughter. They are the future, we are the future, you are the future, and I hope that together we can keep in mind what Dr. Martin Luther King Jr. said, that the arc of the moral universe is long, but it bends toward justice. So the road to the future is probably rocky. This is a rocky road, but we can, at times, when we think about it, envision a future that will be better for our children and grandchildren and great-grandchildren. And I hope we can do that together. Thank you all very much.
Thank you. Thank you so much. Yeah. Thank you so much, Dr. Paula. There is an exciting talk, and I hope and I'm sure all of your dreams are actually our dream, and we would like to dream in like that way. So there's an excellent talk on this, how the future and what we expect to be in this for taking care of our younger girls. Any questions on that to Dr. Paula? Anyone?
No question. We just hope Professor Hillard is right.
Yes.
Thank you.
Thank you for your wonderful talk.
Paula, you've blown us away. That was fantastic. You've also nailed it for the global PAG session, so thank you very much. It means that we might have a slightly shorter session for global PAG because Paula's done it all. Well done. Thank you. Very pleased indeed to introduce our next speaker, who is well known in the lecture circuits in the United Kingdom. Kath White is an expert on childhood sexual abuse. She has been head of the largest sexual assault referral centre in England, in Manchester. Do not get on the wrong side of her, because she's also an expert on strangulation. So, thank you, Kath.
Thank you. Can you hear me okay at the back? Yep, okay. So I've got 30 minutes to speak to you about child sexual abuse, which of course is a huge topic, isn't it? And so I can only give you some pointers regarding it. I've got nothing to disclose. Child sexual abuse, just by its title, it suggests that it's a topic that might not be, well, it's never very pleasant. So a health warning that I've given lots of talks all over the world. I frequently get people coming up to speak to me at the end of talks saying that they've been victims. So I think when we consider the prevalence of child sexual abuse, we have to bear in mind that people in the audience will have been, not may, they will have been affected by this. Talking about prevalence, looking at the World Health Authority figures, so girls, 18% give a history of having been a victim of sexual abuse. So I don't know the people in the audience. Sometimes I speak to people and they say, well, this is something that we don't see. I've not seen it. I would say that if you are seeing children, adolescents, you are seeing it, whether you know about it or not. So to bear that in mind. The other thing to remember is that abuse tends to hunt in packs. So if you're seeing a child who is the victim of physical assault, they disclose physical assault or emotional abuse, it doesn't mean that they have been a victim of sexual abuse, but you need to think about it because it often, as I say, hunts in packs. And the easy cases, I suppose, are where the child discloses. And then you need to think about the forensic needs of the child, the medical needs of the child, the psychosocial. And no one of these trumps the other. Perhaps psychosocial, they're intertwined. As clinicians, we need to be thinking about safeguarding. So what is the immediate safety of that child? This gets a bit more tricky if the child hasn't disclosed, but you have a suspicion, because that can be difficult to broach with the family, with the carers, with the child. The big thing is the voice of the patient. And I don't know collectively if you're seeing patients, children, adolescents, for anything, not for sexual abuse, but how geared up are your systems to hearing the voice of the child, the voice of the adolescent? That is really important, and I think we all need to think about how do we do that, and how do we do that in a safe manner? How you speak to the child, where you speak to the child, who is with you when you speak to that child is really important. So whether it's where you're thinking about child abuse or where you're thinking about anything, how do you get that voice? What is it that you want to hear? And I'm sure you have all developed systems where you can hear the individual voice away from the carer. So I was on call just a couple of weeks ago and I saw a 3-year-old where there was a suspicion of child sexual abuse. And I did say to the mum, I want to speak to her on her own. She wasn't actually quite 3. She was a very articulate little girl. And the mum was fine with that. And so I spoke to this little girl and I asked her, did she know why she was seeing me? And she said yes, because she was sore, where she does her wee-wees. And I said, why do you think you're sore? And she said, because I've eaten too many strawberries. So I'm not sure that was the actual diagnosis, but it was important to hear what she had to say. The other thing is vulnerable patients are vulnerable. That sounds like it's obvious. Sexual abuse can happen to anybody. Yes, that is true. But my years of experience, certain groups are more vulnerable. One of the things that we do as routine for everybody aged over 8 is we screen them for learning disability. And we do that right at the beginning. That's important because we need to know how to speak to people, but also, you know, there's no point us sending letters or giving leaflets to the person who can't read. So we need to get some kind of understanding of this person. Also, when you're thinking about consent, you know, you're taking consent to examine or to do whatever it is you want to do. I don't know what it's like in other parts of the world, but in the UK we often say, we consented somebody. That's not the way you do things or the way you should do things. Thinking about the medical aspects, emergency contraception, and you've had talks about emergency contraception, but we need to be seeing people in a timely fashion in order to be able to do that. HIV, PEP, We need to be seeing people in a very timely fashion. And what can happen in the UK, I don't know if it happens where you are, but quite often the children have to fit into the times of the organisation, not the organisation fitting into the times. So quite often an excuse will be made, well, it's not good to examine 3-year-olds late at night, or it's not good to, to see people at 2 o'clock in the morning. Well, it might not be ideal for me if I'm on call to get out of my bed, but sometimes it is the right thing for that child. So making sure that our services fit them, not them fitting into what we want. Screening for STIs, suicide risk. I don't know how good you are at assessing for suicide risk. Some clinicians are frightened. If I mention suicide, it will make them go off and commit suicide. That is a nonsense. You don't speak to a happy child or adolescent and mention suicide and they go, oh, I hadn't thought of that before. I think I'll try it. Safeguarding. This is Victoria Climbier, a young girl who really highlighted the failings of the system in the UK. We have the sexual assault referral centres in the UK. So at St Mary's, we see well over 400 children a year where there's an allegation or suspicion of sexual abuse. So by a child, I mean under the age of 18. We have 3 forensic suites, one designed for adolescents, one designed for young children, one for adults. But they're designed, we don't go by age, it's by what that particular person requires, where we put them, not chronological age. If you're falling asleep in this talk, fair enough, but just, wake up for a couple of seconds. One of the key messages is that the vast majority of child sexual abuse examinations will be normal, okay? Normal doesn't mean that nothing's happened, and there can be a whole host of reasons why it might be a normal examination. But as clinicians, it's important, in the decision makers in these cases, whether that's, the families, whether it's the clinicians, the police, the lawyers, normal does not mean that nothing has happened. You've heard about colour. We use the Fitzpatrick skin colour scale. It's really important, and you use whatever scale you have access to. But it's really important if you're talking about why, did you find any injuries on the child? Give context. Actually, if they had very dark skin, then what are the chances of you seeing a bruise or redness or a bit of erythema? So give context with that. Just want to talk to you about the Purple Book. So some of you may know about this, some may not. The Purple Book, the correct title is The Physical Signs of Child Sexual Abuse. We are just about to reveal the next edition, the 2023 edition. So there was a 2008, 2015, and now there's going to be a 2023 edition. And what we've tried to do is look at what is the evidence base for how we interpret physical findings. So rather than a gut feeling, I just feel that this sign means X. If we are sending people to prison or not sending people to prison, it's got to be based more on gut feeling, or if I wake up in a good mood or in a bad mood, it's got to be based more on that. So what we've done with this latest edition, just going back, we've worked with the American Academy of Pediatrics, with the Royal Australasian College of Physicians, the Faculty of Forensic and Legal Medicine, and screened multiple papers, sifted through over 20,000 papers, 800 papers were deemed relevant to be appraised by our clinicians, and then included the papers that needed to be included into this latest iteration. So it's been a long process. Chapter summaries are here. I'm not going to go through all of them. There's been a couple of new additions, so oral signs is new to this latest version. And for each chapter, so, basically we've gone through the relevant papers. It's quite hard to get papers where they have where they've excluded child sexual abuse or show how they might be included into it. We've tried to have key messages, evidence statements. Now we have to have an explanation of the difference between evidence perhaps in court as opposed to evidence what we can extract from the paper, but also issues for practice. So, for example, gentle signs of sexual abuse in girls. There were clinical questions asked beforehand, and then through the sift of all the research papers, we've tried to get that information. For some of the chapters, it's quite difficult. There isn't a whole host of good evidence, research evidence-based papers, so it has been difficult to do that. So I won't go through all of this in great detail. I thought you might be interested as a group, so we did one chapter which I was part of the gentle bleeding in prepubertal girls. And then we came out, so I don't know if there's any researchers in the audience, but we've come out with a list of key research priorities, which would be very helpful for whenever we do the next edition. One of the difficulties is people across the world using different terminology. You heard in the last talk about, wouldn't it be great if we referred to vaginas and vulvas, and that's in, with the lay population. Wouldn't it be good as clinicians if we used the correct terminology? Because sometimes it can be difficult to know what the clinician actually means. If any of you are interested in the getting the next edition, so at the bottom here, if you email here evidence at Royal College of Paediatrics childhealth.ac.uk, you will be able to hear about this edition when it's available, and it should be available this summer. I chair the board, and we're very close to the end now for this. I'm not going to show lots of horrible images, but one of the things that we have noticed in the UK, I don't know how many here are from the UK, over probably the last couple of decades, and it's probably due to some legal cases where paediatricians have been criticised, is that a lot of paediatricians run a mile from examining children where there is an allegation or a suspicion of child sexual abuse. I don't know whether that's the experience in the countries where you're from, but a lot get really panicky. This is a case that I was involved with, and it was an 8-year-old girl who gave a history. She's only 8, and she gave a history of about 4 years of vaginal discharge. So 4 years, that's 50% of her lifetime. She had been presented to numerous clinicians, and none of them had ever actually examined her. She had been given numerous prescriptions of treatment for thrush, but no one had seen her. Eventually, she was referred to one of the paediatric adolescent gynecology consultants in the hospital where I work. And Gail Busby, I don't know if any of you know Gail Busby. Gail saw this young girl in her outpatient clinic, took a bit of a history, and then examined the child. And this is what she saw. So Gail pretty quickly stopped the examination and called me in my role as a forensic physician. So what we did is we took the young girl to theatre for a examination under anaesthetic. Obviously, we spoke to the parents and spoke to the girl beforehand and did all the consent, etc. And these were some of the objects that were removed from this little girl's vagina. So I don't know if you can see at the back, numerous pebbles. That the bit that was showing here was like a little bit of Lego. It was this part, which was very close to ulcerating through with this little girl. We have a little doll's shoe. This little girl didn't give any history as to why these objects were there. She said she had no idea. So it was difficult to work out whether someone else had done it or whether she had done it. My gut feeling from talking to her and talking to the family was that this is something that she had done over a number of years. But you know, she could have been left with all sorts of long-term problems because nobody looked. So again, if you're asleep, just wake up for a couple of seconds. Importance is thinking about things and looking. Examine. The other thing that we frequently get referred, you know, if I'm on call, a problem that will frequently come through to me, often with a lot of drama, a lot of emotion, is the little girl who presents to general practice, so primary care, with bleeding, and it can look quite alarming and catastrophic. And it's usually obvious to me in the history taking on the phone that this is what I'm likely to be seeing. Now, I suppose one of the key things I have to say here, just thinking about the prevalence of child sexual abuse, 18% for girls, so that's quite high, nearly 1 in 5, is we can have coexisting abuse as well as other problems. So just because we see this doesn't mean child sexual abuse can't have happened, but just to bear it in mind. Okay, I'm just going to rush on because I see that I've got only a few minutes left. Wake up again, couple of seconds. I don't know if it happens in the country you're at, but virginity testing, don't do it. It doesn't make any scientific sense. It's cruel, it's unnecessary, it's inhumane. Don't do it. Don't give out certificates of virginity. It just doesn't make sense. I can't speak to any audience greater than one person, myself, without mentioning strangulation. I'm now the medical director of the Institute for Addressing Strangulation. So I've got a captive audience here. Think about it. It happens far more than you might think. including with children. So you may see signs such as subconjunctival hemorrhages, petechial hemorrhages. Just consider strangulation. What we hear from the paediatricians is they may have something like the Darth Vader lift. So my world is the sexual abuse world, but you might get it in physical abuse, where the child is lifted by the neck. So think about it. The other thing, I don't know, are you all familiar with the ACEs? Yeah? Anybody not? Some people looking at me a bit blankly. Okay, so consider the ACEs, consider the ramification of the ACEs, the adverse childhood experiences. I've put on here the link to the original paper, the Vince Folletti paper from San Diego, 1998. Really worth a read. The other is a TED Talk by Nadine Burke-Harris. I think it's only something like 15 minutes long, but really useful way to spend 15 minutes. Just listen to her talk. Very powerful. That will, if you don't know about the ACEs or you only know a bit about the ACEs, please turn to that. Quickly, the Faculty of Forensic and Legal Medicine, if you go on our website, which I'll give you the website address in a second, got lots of documents which you may find useful. So one of them, I like a flow chart, because when I'm on call in the middle of the night, even if it's not the middle of the night, my brain doesn't work very well. I like to, work through a flow chart about everything. Life. So one of the things that I created was a guide to whether you see your 3-year-old at 11 o'clock at night or whether it could wait till the next day. Now, of course, you always have to take a holistic view, but this would help you. We've got one for post-pubertal and we've got one for pre-pubertal. And it would help you decide about when to see children. The other thing we have is every 6 months, we look at the evidence base for forensic samples. And then we come up with guidelines on which forensic samples should be taken, how do you take them, and what are the time frames to take them. And we update this every January and every July. And there's 2 documents. One is the actual guidelines, and the other is what the evidence base is for those guidelines. And anybody can email us. So our next meeting is in 2 weeks' time. Anyone can email us with a question. And in the committee, we have clinicians like myself, but we also have forensic scientists. And we will consider the question and then use it to inform the guidelines. The guidelines are not training documents, so it can't stop you from training your cohort of clinicians, but it should help. And then lastly, I've spoken very much from a UK perspective, but this is a very useful document, World Health Authority document, which would help you, just gives a rounded view about responding to child maltreatment, with a lot of the references there if you need any of the references to make an argument for your particular country. Thank you very much.
Thank you, Catherine. That was wonderful as well as comprehensive coverage on child sexual abuse. I just would like to, one aspect in that is because you discussed something about legal aspects also. Sometimes which actually impacts on the clinicians. So I'd like to brought in relation to this, like in India, for prevention of child sexual abuse, there is a POCSO Act. So that is Protection of Children from Sexual Offences Act 2012. Now what this it is onus on the clinicians. That is this PAG clinicians, that any girl, those who comes and report to us, that is she is sexually active and mandatorily report to the police because being sexually active. Now this is hampering the care of the younger ones because one are actually now knowing the impacts or knowing this clinician may do, and it put the problem to the clinician also because it puts on your burden, it puts on you reporting those matters also, and as well as the girls actually don't want to come. So sometimes we put the legal or legislation aspect actually, although I don't want to discuss what the politicians are doing, but what do you see that is we need to negotiate as clinicians for us to take cover of those?
So I think the issue of mandatory reporting is an important one, and it's been raised in the UK. So as a clinician, I would have a safeguarding duty. If I thought a child was being abused or being exploited, I would have a safeguarding duty there. If I saw, say, a 16-year-old who I felt was competent and was in a sexual relationship and I didn't feel that she was being exploited, I would not have to refer on to anybody else. So it's up to us to, certainly in the UK, to do that assessment as to the competence of the child, their level of understanding about what's happening, and the context of how we're seeing them. You know, if I was seeing a child and the allegation is of abuse, then that makes the job quite easy. But if I was seeing a young person who said they were in a consensual relationship, then you have to explore that more. And I do think it's a knee-jerk reaction, the mandatory reporting, because I do think it can do a disservice to the children. Like you say, it acts as a barrier to them.
Correct. So it is not the legislation aspect. It doesn't say it is the abuse. It says anybody is either the physician's feeling or they are just reporting. It may be a consensual sex also. Anyone below 18 years, married or unmarried, irrespective of they are supposed to be reported by the clinicians. Failure to report, if it is there, 6 to 12 months of imprisonment is there or with the fine. So it is really puts. Now what is, as we have to see, is because it's very difficult to see. What most of the time it's very difficult. We usually don't document. If it is not, it's only just for treatment purpose or like that. That is the way at current situation is going on, because otherwise there is legislation is very strict.
Yeah, and I think I've worked in lots of areas across the world, and where you have mandatory reporting, one of the issues is people don't report. So I'm sure it's more complex than that, but it's certainly a big barrier, and that's adults as well as. So in the UK, I could do a forensic medical examination of an adult who didn't want to report to the police. The police pay for that examination, they get the full service. But we don't have to pass that information on to the police unless I felt they were a vulnerable adult and I felt that they were at ongoing risk or there was a public risk. And that was a bit of a hurdle for the police to get their heads round initially, but actually these people just don't come forward otherwise and they don't get any help. So I do think that there needs to be a way that we can see these people, clinicians can see them and offer the help without there having to be an automatic referral to the police.
Thank you so much. Paul, anything?
No, Kath, that was very elegant. Thank you so much. We're very grateful you could join us and share your expertise. And we hope to see you later at the gala dinner. Thank you very much.
Thank you.